Before I start, I will be talking about what is an orthoptic evaluation. So orthoptic evaluation basically is one of the most important parts whenever we talk about one clinic practice. So in orthoptic evaluation, when we say it should be a part of your routine practice as well. Some of the parts of this evaluation should be done routinely with each patient so as to understand that if it does the patient require more tests or not. So let's start with our presentation now. So what are the learning objectives what we will be going through today? First is what we'll be understanding is about what is an orthoptic evaluation. I would be telling that what is orthoptic evaluation. Second is what are the tests included. So there are many tests which generally are listed. So we will be looking on to the tests which are generally required or basic tests which are used to diagnose a patient with a non-strabismic binocular vision anomaly or an orthoptic evaluation and how to perform them. So basically this test which I'm going to talk about, so we'll be looking at how to perform these particular tests and whatever results we are getting from this test, how to interpret these findings. So these are the objectives which at the end of the presentation, I hope everyone would get them. So let's start with what is orthoptic evaluation. So when we say the term orthoptic evaluation, it means that if a person is coming to you for an evaluation, so you are assessing both the binocular vision completely with accommodation and vergences, because these are the two main components which are giving you the vision properly. So accommodation deals with the clarity of the image, whereas vergence will make it singular. So both of them are quite required and important to understand that if a patient is having a proper visual what we say vision. So in battery of test, when we say the term battery of test is basically the set of tests which are generally used in your orthoptic evaluation. So these are your tests which are generally done. So first of all, what we all start with is history, but here the history is slightly different. It is not like what we take in our routine checkup. Then vision, what vision plays a role into your orthotic evaluation. Next is refraction. What refraction would we generally prefer? Next is your Phoria measurement, that is the amount of deviation which is kept latent. We need to measure that. Fusion, that is basically how much the Phoria or whatever the binocular condition patient has, it is affecting your fusion. And finally, the third grade, that is your stereopsis, how much that is affected. Now, that will give you an idea that what type of treatment has to be given. Next is your MEM, that is your monocular estimation method. So that gives you a fair idea about what is your accommodation and how much is it getting lead or lag. Next is your NPC, that is near point of convergence. Then there is your NPA, that is near point of accommodation. Your NRA, that is your negative relative accommodation. PRA, that is your positive relative accommodation. Amplitude of accommodation, accommodative facility, and NFV and PFV, that is your negative fusional vergence and positive fusional vergence. So we'll be looking through all this tests today. So in this test, there are some of them which are basic, okay, and which are combined. So like they use both your accommodation as well as convergence. There are set of tests which are only particular for your accommodation analysis. And finally, there are set of tests which only assess your vergences. So we'll be going through all this test and understand what are these different tests and what are the interpretations. Starting with case history, when we say here we don't ask irrelevant question, there has to be very much specific with whatever you ask, because here the patient, when he comes up to you in a form of orthoptic evaluation, he generally has three symptoms. Either it would be asthenopia, either it would be because of that blurring of image at any distance or near, or either it would be diplopia. So any three of this would ask the patient to come to you. Basically, these are the points where the patient is coming to you. So what I should ask should be very much relevant to the patient's symptom. So whenever we discuss things with patient, it should be quite objective as well. It should be recorded properly, because you cannot just make assumptions. So there has to be a scale where we can measure that how much severe or how much difficulty the patient is having. Is it normal? Is it mild? Is it moderate? How much exaggerated the treatment protocol should be, or how much the person should be taking the therapies, and what is the requirement. So whenever you ask any question, for example, do you feel difficulty while reading or to read? So it should be graded on a point scale, where could be never, that is zero. So if the patient says, I don't have any such difficulty, that is zero. Sometimes that is graded as one, often that is graded as two, and finally very often that is graded as three. So this will give you finally a score. There is a set of 14 questions which you can ask the patient that will give you a rough idea. Does the patient has a problem because of your visual system or is because of something else? So let's start with what are these questions. So the first question which you generally ask is, do you feel tired or uncomfortable when reading or doing close work? So this question very specifically gives you an idea that does the patient have problem while reading, or like for near work, or is it for distance? So if the patient is telling you yes, that then most of the time either it could be your accommodation or your convergence, which one is getting affected. The next question is, do you feel headache when reading or doing close work? Now headache could be because of your excessive use of accommodation, or either it could be use of excessive of convergence. There are other also, but this actually gives you a fair amount of idea that is it because of your accommodation or is it because of the convergence. The next is, do you feel sleepy when reading or doing close work? So this is basically a sign that the patient is having fatigueness. So because of that fatigueness, the patient is unable to concentrate continuously, and that would lead to such kind of symptom. Do you lose concentration when reading or doing work? So what happens here, that if the patient is unable to concentrate on one particular line, that is basically that the patient is unable to use his vergence properly, and he is unable to follow or track a particular line of letters. Next is, do you have trouble remembering what you read? So if your saccades and pursuit, which we generally see, is not proper, then every now and then the patient might forget that where exactly was his point of fixation, and then he would have the problem that where was I reading that I'm unable to find. Next is that, do you have double vision? Now this gives you a very clear cut idea that the patient is having a problem in vergence. The moment the patient tells you that I have a double vision while reading after 10 or 15 minutes, so that gives you an idea that the patient is having some problem. Either it could be convergence excess or either it could be convergence insufficiency. So that will give you an idea that the patient is having a problem with his convergence. Next is, do you see the words jump, swim, or appear to float? Now this again could be because of mix, that is either overuse of accommodation or because of the convergence. Next is, do you feel that you read slowly? Now this point very clearly makes you understand that because the patient requires more stimulus of accommodation to clear a particular line, he will obviously read slowly. Every now and then he shifts his word, the word takes time to clear out, and that is leading to a slow reading procedure. Next is, do you ever hurt or feel sore when reading or doing a close work? So does the patient feel soreness around his eye? Does he feel that he is hurting, rather the eyes are hurting, or burning sensation? Now that is again also a point where it would show you that the patient is having fatigueness. Next is, do you feel a pulling effect, or rather feeling around your eyes while doing close work? So we all know that when we excessively use our accommodative muscle, that is a ciliary band which is being used, that will exert a pull around your eye, which is many time patient says that there is heaviness around my eyes. Next is, do you feel or notice words blurring or coming in or out? So when we say that term in or out, that is basically because of your excessive use of accommodation. When you use this accommodation, there is a plane of accommodation which we say. So when the patient is using excessively accommodation, and many times what happens, if there is a convergence insufficiency, the patient tries to accommodate more so as to he can do your accommodative convergence. Now again, that would also lead to the same effect. Next is, do you lose your place while reading? Again, the same. If the patient is unable to track the letters properly, he will have the same problem. Next is, do you have to read the same line of words when reading? So many times, if you are not following or not tracing the letters properly, this commonly happens. And do you avoid reading or close work? Now, this is generally seen in child. Small children, they generally, whenever have such problem, they try to avoid, or rather in adults, when we see, what they do is they keep their system, or rather they keep their books a bit away at a further distance so as to compensate for whatever problem they are having. The next is vision and refraction. Now, vision and refraction is one of the most important part in your orthoptic evaluation. So many times a common problem or common mistake I have seen, that many times people just see if the vision is 6/6, that means there is no point of refraction. That is completely wrong, because if the patient is having some amount of latent refraction left, or latent what we say, your latent hyperopia, so that could actually change the complete evaluation. because that small amount of hyperopia which the patient is correcting by his own accommodation will interfere with all the tests and give you over or under readings. So that could interfere with the MEM readings, that could interfere with your NRA, PRA and everything. So whenever we say this vision has to be taken properly, and even if it is 6 parts, still go for the refraction. Now, one more thing, many times we have seen that while doing so, many people say, just forget the taking your near vision. So now we say that near vision is again very important. Now, as you saw in the earlier questionnaire, most of the problems which were written were regarding the near. Now, when you are giving for near vision, just not only your booklet, the one which you have for reading, ask your patient to read a newspaper for at least 2 minutes. That will give you an idea that even if the patient is having some problem, that will take a bit time to get obvious. Because initially, if you show simple one word, the patient will easily read. But when you ask him to read continuously, that might show you the defect which is present. The patient might tell that, no, I cannot see the next line, or rather it takes time for me to see the next line. So vision is actually a very important part here. And I would rather say it is always preferred to have a cycloplegic refraction done. So because if there is any latent amount of refraction present, that can be done and the patient should be given the complete refraction. The next point which we see is a very important point whenever we are detecting Vergence problem, because Phoria measurements lies to be one of the most important clues that will give you that is it a divergence problem or a convergence problem, is it for distance or is it for near. So Fourier measurement, when we do, is your two types that you can do it qualitatively and quantitatively. So when we say the term qualitatively, so qualitatively it can be done with the help of your Maddox rod, a very simple test. You place the Maddox rod, what we say, your horizontally, and then you ask the patient that can he see a dot and a line. And depending on the interpretation, you can find out is it an iso deviation or an exo deviation. So the simplest way to understand is your crossed and uncrossed phenomenon. So whenever we say, I have a simplest synonym that in exodeviation, there is an X present. That means it is crossed. So crossed means the eye which has Maddox, for example, here it is the right eye which has the Maddox, the patient will tell that the line is onto the left side. That means it has crossed the nasal line or the visual line and it is being seen onto the opposite side. So if it is a cross deviation which patient is telling you, that means it is an exodeviation. Whereas if it is an uncrossed deviation, for example, the patient says the line is onto the right side and the dot is onto the left side, the same side the line is present. So that will be your iso deviation. So this gives you qualitatively that what kind of your deviation the patient is having. After that, which you can do is doing a quantitative examination. So once I know that it is a iso or an exo deviation, I can use the prism bar cover test to find out the amount of deviation. So the simplest idea is to keep the base opposite to the deviation. Okay, so if it is an iso, you will take it base out. If it is exo, you will take it as base in, and then you will do the according your big prism bar and cover test, and you can find out the amount of deviation which is present. The next is fusion. Now, why fusion is being tested here? Because as we saw, it is a latent kind of deviation. So how much that deviation is affecting my fusion and stereopsis. So the moment it will deviate my fusion, automatically it will affect the stereopsis. So many times we see that the patient does have an amount of Phoria, but he has good control, or because of the good, what we say, motor fusion, the patient can easily make it again single and he has no such obvious defects. But because of the excessive use of motor fusion, the patient will have asthenopic symptoms. So in fusion, generally what we see is your Worth 4 dot test. I hope everyone, whoever is attending right now, might have done this test once, or at least might have read or seen this particularly. So here what we do is we ask the patient to wear an anaglyph, and then we ask them to look at the screen where there are 4 dots present. So there is one red, two green and one white. So the normal which we get is that the patient should say that there are 4 lights in total, and among them 2 are green, one is red and one is flickering. That gives you that the patient doesn't have any defect, or rather any kind of squint, and the patient has good amount of fusion present. Generally, you can also see that is there a suppression present or not. So suppression would be that whatever eye is being suppressed, that colored dot will not be seen to the patient. So if the patient says that the red color is not visible to me, that means that the right eye is suppressed. If the green is not visible to me, that means the left is suppressed. And in terms of your deviation, if the patient has any squint or any phoria, and if there is a diplopia present, the patient will tell you that 3 dots are one side and 2 dots are on the other side. Again, the same concept of your crossed and uncrossed deviation here. So if the patient says the red is right in front of the right eye and green is right in front of the left eye, that means it is an uncrossed deviation, suggesting you that it is ESO. Whereas if the vice versa is there, the patient has exodeviation. So this is an instrument right in front of you which is used for near. Now fusion not only for distance, but you need to also check if the fusion is same for your near. Many times what we see, the fusion is intact for distance, but because of the problem in convergence, the patient has lesser amount of fusion, or fusion is deteriorated at a near gaze. So generally this torch, which has 4 lights, again you do the same procedure, but this is done at 40 centimeter and you ask the same interpretation. The next is your stereopsis. Now, stereopsis will tell you about how the treatment protocol or how rigorous the treatment protocol has to go, because here we understand that the whatever concepts we are talking about, binocular singularity, fusion, and everything, is it giving you the final thing, that is what is your stereopsis, and is it present, and if it is present, up till what extent is it present, how much the patient can cope up with whatever problem he's having. So in stereopsis, again, we have 2 types. So there is something, this already every one of you might be knowing, titmus fly test and your circle test. So there is a drawback in this test. This is called as a local stereopsis test. Why local? Because here what phenomenon we use it, we use the same image and slightly displaced with one another. So any patient who doesn't have proper amount of fusion and stereopsis can also pass this test because of the monocular clues which are seen here. So even if ever you have noticed that even without your Polaroid filters, you can tell which one is having the decentration. So that is the monocular clues are present. So even a patient who has some amount of squint can pass this test, and that is one drawback. Whereas the other test which we generally see is your random dot stereo test. This is called as your global stereopsis. Now global stereopsis means here the dots are placed randomly and there are no monocular cues. So global stereopsis will give you a much more accurate reading that what is the exact amount of your stereopsis present in the patient, how good the fusion is helping him to see an image into a depth perception, or what we can say as the 3D view. Whereas local stereopsis, as I said, the patient can have a slight tilt or something and he can find out that which one of the particular object is having a depth perception. So it is easier to cheat into your local stereopsis, whereas in global stereopsis, you are unable to do so. The next point is near point of accommodation. Now near point of accommodation stays very important here, because this gives you a rough idea about, is the accommodation playing well, is it excess or is it less. So how we do this procedure, simple. RAF ruler, what you can use is, so what you do is you put a near reading chart over this particular thing, and then you ask the patient to read one line lesser than the best line possible. So the patient can read N5, so you ask him to read N6. If he's reading N6, you ask him to read sorry, N8. So after that, you take this target closer and closer to the patient, and you ask him to report at what point is it getting blurred, the sustained blurred, the where the patient is unable to see it further. So this is where the patient need to tell you that there is no more clarity in the image and he is completely seeing it blur. Once that is done, that is called as the your blur point. So you take the image again away from the patient and you ask to tell that at what point is it getting cleared. So that is how you do the near point of accommodation. So what near point of accommodation tells you is what amount of amplitude of accommodation the patient is having. So it is an indirect way. So what you do is, if you're taking the value in centimeter, so 100 divided by the NPA value will tell you roughly about how much amount of accommodation is present in the patient, or how much amount of accommodation the patient can do. The next point is your amplitude of accommodation. Now, amplitude of accommodation is again the amount of accommodation which can be generated by your lens. So this can be done in different ways, but one of the ways which I prefer is the minus lens method. So in minus lens method, what you do is you keep the particular chart at one particular point. So I generally prefer at 40 centimeter. and then we put increasing values of minus lenses in front of the patient's eye. So as the minus lenses increases, the patient has to accommodate to clear the image right in front of him. So how we do this test? We ask the patient to clear the image. The moment he says it is clear, we again increase the power of lens. We do it until the patient says that even after a blink or even after trial, he cannot clear the image, which is called as the sustained blur. So value, whatever the minus value you are getting, like for example, whatever value you are getting, like 8 or 10, you add 2.5 over it. Now, why this 2.5 is added? This is to correct the distance. You're already holding the chart at 40 centimeter. So even without any lens at that distance, what you're doing is you're using an accommodation of 2.5 diopter. So over that, we are putting minus lenses. So whatever value is coming, you add 2.5. So let's say if the patient could read it with -8 and further that he was unable to read it clear. So if it was a sustained blur, the patient's total value for amplitude of accommodation would be 8 plus 2.5, that is your 10.5. So how do I understand that is this value normal, below normal, or above normal? So because we need to understand that is it accommodative excess or accommodative insufficiency, or is the accommodation normal? So there is something called as a Hofstadter's formula, which says that the average value should be 18.5 minus 1/3 of age. So whatever the age you have, you divide it by 3 and subtract that value from 18.5. The value which you will be getting should be the average value of accommodation in that patient. So now what is the standard deviation? Like for example, you are getting a value, but there has to be a standard deviation because we have done it in a big population. So a standard deviation of around plus or minus 2 diopter is quite accepted. So whatever value you are getting, plus or minus 2 diopter, if your value is ranging within it, so then the value is normal. Minimum value. So that was about average value. So what should be the minimum value, or rather the least value of accommodation which should be present for a healthy individual? So it should be 15 minus 1/4 of the age. So whatever value of the age is, you divide it by 4. So like for example, it is 20, you divide by 4, that comes 5. So 15 minus 5, 10. So 10 is the value of minimum accommodation which should be present. So I hope everyone understood about what the amplitude of accommodation is. So just a question for all of you, that let's say a 15 years old patient gets a sustained blur at -7.5 diopter at a distance of 40 centimeter. So as compared to the average value, the patient will have normal, reduced, or an increased value. So just give your answers into your comment boxes. So let's see if you understood it properly. Just to add something, someone asked about what is the normal range of NPA. The normal range of NPA would rather depend on the age. As I already said, it is age dependent factor. So you just convert it into the form of your amplitude of accommodation and you just see if the person is having a normal accommodation or not. So it will be completely dependent on how it is. So there is no such fixed that you can say this and this. So it is simple that, for example, you are telling me that what should be the normal amount of NPA for a patient with like 18 years of age. So I would rather say the amplitude of accommodation comes somewhere around 13. So when you divide 100 by 13, your value should be lying somewhere around 6 to 8. So around 6 to 8 centimeters should be the amplitude of accommodation. That is how we understand it. So I guess everyone has already answered. So the value here is reduced. So how do I get this value? So 15 years. So as I already said, the average value is found out by 18.5 minus your 1/3 of the age. So that is 15 divided by 3, that is 5. So when you subtract 18.5 minus 5, that will give you 13.5. So 13.5 is the expected average value. And as I said, plus or minus your 2 diopter. So least you can get somewhere around your 11.5. So for the patient which we are having right now, 7.5 diopter is the value which you got, and you add 2.5. So you get a value of around 10. So the value is slightly reduced as compared to the average value which you are getting. So coming on to the next assessment of your accommodation, till now we were only talking about the what we say amplitude. So amplitude is something which we gives only the quantity, but we should also know how much your accommodation can stimulate and relax, how quickly it can do that. So negative relative accommodation is nothing but it gives you an idea that how much amount of accommodation you can relax, because we all know there is a mechanism of accommodation relaxation and accommodation stimulation. So generally this is done by the help of a plus lenses. So what you do is you introduce plus lenses right in front of your eye and you give the target at 40 centimeter and you ask the patient to clear the image. Now, as well as clear, you should also ask if there is any diplopia or not. Now, why this diplopia, we'll see to it. So this is done generally with plus lenses. So endpoint should be a sustained blur. The patient should tell you that he can no more clear the image, and it is an ability to relax your accommodation. So this will give you an idea, is the patient able to relax the accommodation properly? So patient with accommodative excess will not be able to do this because they are already using the accommodation so much that they are unable to relax their accommodation. It is an indirect method to evaluate your convergence. Now, how we do that? So in the image, if you can see, we are using a plus lens, right? So plus lenses are also called as your base to base lenses. So when you're looking at a near image, so your image is going from this part at the nasal side, so your lens will start acting as a base out prism, and base out prism are actually used to evaluate your convergence. Now, one more method which I'll be telling you about, how are we actually evaluating a convergence, that simply when you put a plus lens right in front of your eye, it will, what it will do is it will relax the accommodation. So the moment it relaxes the accommodation, the accommodative convergence also relaxes, and you need to use your fusional convergence to cope up with it. So because the eyes are going again into a divergent state because of the accommodative convergence getting relaxed, you need to use your positive fusional vergence, that is your fusional convergence, to keep the image single. So what generally we see, two patients are unable to do this test. Either if you have a accommodative excess, if you are unable to relax your accommodation, or else if your convergence is less. So if your PFV, the value of positive fusional vergence, is less, you will be unable to converge properly. And if you are unable to converge, this plus lenses will make it difficult for you to keep the image single. And rather than blur, the patient will quickly tell you that it is not blur, but it is double for me. So that tells you indirectly that the patient is having a problem in his convergence. So expected value for this is your plus 2.5 diopter. So these are the values which I have taken from your clinical orthoptics book, that is from Shimins. So next is your positive relative accommodation. Now, what is a positive relative accommodation? It is just opposite of your negative. So when I say the term positive relative accommodation, that means how much I can easily accommodate, or rather how much easily I can generate the accommodation. So simply it is done by with the help of your minus lenses. So in minus lenses, what happens that whenever I put a minus lens right in front of your eye, so to clear the image, or rather to counter that minus power in front of your eye, you will induce some plus power with the help of your accommodation. Or rather, in short, if I say, you will accommodate to cancel out the minus power effect in front of your eye. The moment you do that, you will start converging at the same time, because if you're accommodating, you're also converging. So it is the endpoint again the same, it will be sustained blur. You ask the patient to tell you at that point where he cannot clear it, which further effect, or rather further efforts, he cannot clear the image. Okay, so here the ability to stimulate the accommodation is being assessed. And also it is an indirect method to assess your divergence. I'm really sorry, there is a problem here. So it is basically to see the amount of divergence, how much you have. So what happens here, that when you put a minus lens right in front of my eye, I start accommodating. And the moment I accommodate, I also converge. The accommodative convergence is a part of it, and it will start acting. And to counteract that convergence, you need to keep the eye straight, and you will use your negative fusional vergence. So because of that excessive convergence which is happening because of your accommodation, the diverging muscles need to start acting and keep the eye into same earlier position. So with the help of minus lenses, you are assessing your negative fusional vergence or the divergence ability. Also, one more point to understand, that your minus lenses are nothing but these are your apex to apex lenses. The lens is thinner at the center, so they will act as a base in lens. So when you look at a near object from the sides of your lenses, like at near point of fixation, it will start acting as a base in lens, and these lenses will give you the value of your divergence. So generally, the expected value what we stop at is minus 2.5, but that will depend. Now again, it will depend on the amount of divergence which you are having, that how much amount of your PRA value you can do. So also it will depend on to the amplitude of accommodation. If my amplitude of accommodation is good, and if my negative fusional vergence is good, I can go further higher than minus 2.5. So many times what we see is that the patient can go up till -6, -7. That means he has good amount of divergence ability. But many times the patient has good amount of amplitude of accommodation, but he's unable to go up till a higher power because he doesn't have good amount of divergence ability. Coming on to the next point, that is your accommodative facility. Till now, what we were talking about is the amount which can be generated, or how quickly you can your stimulate, or how quickly you can relax your accommodation. Now, when we say the term accommodative facility, this means how quickly you can stimulate and how quickly you can relax your accommodation. So not only the quantity of your accommodation, but its quality also matters. Like for example, I'm sitting at an office desk and I'm looking at my PC or computer, and then suddenly I have to look at a distance. So it should be very rapid, that I can accommodate and relax at very quickly or very spontaneously, to give me a proper binocular vision effect, or rather a proper vision for me, which is not giving me any problem. Many times what happens is that the patient comes to you and complains that I can see distance and near both clearly, but it takes time for me to clear it out. So that means the patient has amplitude and he has good amount of accommodation and relaxation, but at the same time he's unable to do it very quickly. That means the facility is not very good. So how it is done, we generally use flippers, or what we call as the accommodative flippers. So these have set of your plus lenses on one side and minus lenses onto the other side. So what you do is you can do this procedure monocular as well as binocular. So when you are doing it monocular, you are completely assessing only accommodation, because the moment you close one eye, there is no role of convergence or divergence. You only assess the accommodation. Whereas when you do it binocularly, it gives both accommodation as well as your convergence and divergence both to play. So as I explained earlier in NRA and your PRA, that you use accommodation as well as your convergence and divergence whenever a set of lenses in front of your eye, the similar concept is used here. So the expected findings within 1 minute should be somewhere around 8 CPM or more. So now what is 8 CPM? So one plus side and one minus side is taken as 1 CPM. So if I read once with plus side and once with minus side, that is 1 CPM. Or the other way, what you can do is you give the patient a chart at 40 centimeter and ask him to read. Now introduce this flipper right in front of the patient. Start with plus. Ask him if he can clear out the image. The moment he clear it out, that means that the patient has cleared, and then you change it. The moment he says clear, then you need to change, go on to the minus side. The moment he says again it is clear, you change on to the plus side. And you repeat this for 1 complete minute. So the other way, rather calculating the CPM, is you just calculate how much flips you are doing. Like for example, 1 plus, 1 minus, 1 plus, 1 minus. So total 4. So total 4 flips you have done divided by 2. So that will give you the amount of cycles per minute. So whatever amount of flips you are doing, divided by 2, and you will get the value. What are the other findings which we generally get it? Lesser than 5 CPM and slow in both plus and minus. That generally happens if your Vergence are not quite good. You are unable to do your either the accommodation or the convergence or divergence, which are not acting properly. 0 CPM and can't clear the proper lens. So what happens here, if you can't clear your plus lenses, that means, as I said earlier, plus lenses, what we assess in plus lenses, either it is your accommodative excess, your accommodative excessively, or either you are not converging properly. So if your accommodation is too much, or if your convergence is not working properly, you will not be able to clear the plus side, and that is counted as 0 CPM, because you are not cleared the image at all. The second is 0 CPM and can't clear minus side. So when this happens, is the patient is unable to accommodate. Cases in accommodative insufficiency, or else if the patient has divergence insufficiency, the patient is unable to diverge, or the negative fusional vergence is not working properly. And finally, your 0 CPM, that is your with plus and minus both the patient can't do. So there is something called as your accommodative infacility, where the patient is having good amount of accommodation, but he's not very well with the accommodation stimulus and relaxation. So this generally happens, or these are the common findings which we find in your accommodative facility testing. In the next slide, I'll be showing you how this test is done. So here the patient is being tested for monocular facility. So if you see, the patient is asked first to read with minus, and then he's being used to plus. Now here the patient is unable to answer with plus side, and she's taking time. So because time is more taken, and here it is a monocular test, we are assessing the accommodation. So as I said earlier, plus lens will be problem when you are excessively accommodating. So because the patient is excessively using the accommodation, she's unable to relax it, and because of that she's taking more time to clear the plus side. So the moment you see minus side, why is it getting very clear, easily clear? Because already she's using lot of accommodation. So this is how you do. You repeat the test for at least 1 minute, and then you find out that how much time the flips were done, and you divide by 2 and you get the CPM, or the cycles per minute. So here what we have got is rather 2 CPM hardly. So the patient is taking a lot time. So what we will write, 2 CPM difficulty with plus lenses. That means the patient is having difficulty in plus lenses, because the only condition here what we can find out is monocular. So only accommodation is playing a part. So the patient is having accommodative excess. The next here what we are going to see is that how binocularly it is done. So here the target is given right in front of the patient and both the eyes are open. So what you do is you ask the patient to tell you the moment it is clear. The moment the patient says it is clear, you will flip the lens and then ask for the other side and see how much time is again taken. So the moment it is done, you flip it. So if you see here, the patient previously was having difficulty with plus side, but here she's doing quite easily, because of the fact that if your accommodation is not working properly, your convergence helps to it. Your convergence and divergence. We all know there is a triad, that accommodation, meiosis, and your vergences. There is convergence. So when accommodation is unable to do so, your convergence will help you. So many times what happened, we see a big difference between the monocular and your binocular facility. So generally, if the patient is having only your accommodative problem, he will have more of problem in monocular. Whereas if the patient is having a convergence, or rather what we say a vergence problem, binocular will be more lesser or difficult for the patient. So I hope everyone understood that. Next point is your MEM retinoscopy. Now MEM retinoscopy is again very important tool to assess what is your accommodation. Is it leading or lagging? So is the accommodation being excess? Is it normal or is it below normal? Also, not only your accommodation, but also your convergence will play a huge role, because indirectly it is assessed here. So what you do is you generally use a retinoscope with an MEM card. Now MEM card is nothing but it has some pictures or letters written over it. So you ask the patient to fixate at this and you ask him to read. Now importantly, please ask the patient to read or tell you whatever objects are made. So that will make you aware that is the patient actually focusing right over the target, or is he not focusing. Because many times what happens, when you ask the patient to just look at the target, the patient doesn't concentrate there and you cannot assess the accommodation properly. So generally this test is done at 40 centimeters. So you are 40 centimeter away from the patient. So the retinoscope is at 40 centimeter and you ask the patient to fixate at that, done with a full near correction. Very importantly, when we say near correction, so it has to be done whatever amount of hypermetropia or myopia the patient is having, you need to put it into your trial frame and then do it, because that will interfere with your reading. Like for example, if the patient is your hyperope and you are not giving the correction and doing an MEM, it will show you a higher value, more plus value as compared to the normal. And if the patient is a myope and you are not putting the lens, the patient might give you a lower value and so on. So it is again very important to do it with full correction. Then what are the expected findings which we generally see? So the normal value which should come for a patient is between 0.25 diopter to plus 0.75 diopter. Again, very importantly, whenever you are doing MEM, you never keep the lens for a longer time in front of the patient, because if you keep it for a longer time, like 5 seconds or 10 seconds or more than that, what will happen, the patient will quickly adapt his accommodation as per the lens kept in front of him. So let's say if I put a plus lens, the patient can relax the accommodation and again you will see a movement right into your pupillary area. So what you do is you keep your retinoscope ready, you keep on moving the streak to see what amount of your movement is present, and accordingly take a lens, put it and see if the movement is changing or neutralized, and remove the lens very quickly. So that is the key whenever you're doing your MEM retinoscopy. So these are your normal findings, but what about the abnormal findings? So if there is the value is higher than 0.75, that means there is a lag of accommodation. The patient is unable to accommodate at that particular point, and that would lead to your having higher values like +1, +1.5. Whereas values lesser than 0.25, like for example plano, minus 0.25, minus zero point 0.5, these all will be your lead of accommodation. Because the patient is using excessive accommodation, you need to use this lenses to neutralize that much amount of accommodation at that particular plane. So this is what we generally do your MEM retinoscopy. The second thing which we should know is your about next is what we say the convergence, how convergence plays a role in interpretation of MEM retinoscopy. So giving you a simple example, that for example I was having convergence insufficiency. So the way to overcome this convergence insufficiency, what I'll do is I'll accommodate further, so that accommodative convergence can work and give me a singular image. So because of convergence insufficiency, what is happening, I will see that the patient is having a accommodative excess. Whereas vice versa, when the patient is having a convergence excess, what he does to reduce the amount of your convergence, he will also reduce the amount of accommodation, and the patient might show a lag of accommodation. So this is also indirectly you can assess that the patient is having a convergence or a accommodation problem. Next is your near point of convergence. I hope everyone knows this very much clearly. So the one technique which we generally use is using an accommodative, non-accommodative target generally. So you show a pencil or a pen or tip of a pen. Many times we use a small torchlight and ask the patient if to say that the moment it gets double. Now there is a difference between this and this test. This is called as the PLRG, that is pen light and red green test. So in the first test which was shown, the patient can still use his what we say the amount of motor fusion, or rather the sensory fusion, to keep it single. But the moment you use your pen light and green method, the complete fusion is broken, and rather what we can say it is dissociated, and you can get a better value, or rather the exact value, that is the patient having any problem or not. Many times you can find out that in the first method you get a normal value, but the moment you do a PLRG method, that is pen light and green method, the amount of Phoria becomes manifest and the patient gets a receded value of your NPC. The normal value of NPC should range somewhere between your, as per the Shimon, or rather the different books, it is rounding between 3 to 5 centimeters. Now also there is a standard deviation of around ±2. So depending on different studies, they have different values, but most of these studies say somewhere between your 3 to 5 plus the standard deviation. So if you want to get a better value or better understanding if the patient is actually having a problem or not, PLRG is the method which should be used, I suggest. The next is about your negative fusional vergence. So negative fusional is nothing but your assessment of the divergence, or rather how much you can diverge. So it is done with the help of your basin prism. So this can be done both for distance as well as for near. So what you do is you put a basin prism that you're with the help of your prism bar, you keep it at base in, and then you ask the patient to look at a particular line target or any singular target which is non-accommodative in nature. So that shouldn't be a letter or anything. It should be rather preferable if it is a line. And you ask the patient to tell you if that is a double. The moment it is double, that means it is a break. And you ask, reduce the prism bar again to ask him when it becomes single. So it is assessing your amplitude of divergence, how much amplitude or how much amount of divergence you have. The expected findings which we have as per your, again, Shimons, is distance we get a break at 7 ±3 prism diopter, recovery at 4 ±2 diopter. So these are the reading for your distance. Whereas for near, you generally have a reading of 13 ±6, and recovery at your 10 ±5. So let's see a video in which we will see how it is assessed. So here we are assessing the ability to diverge for the patient. You keep the prism bar basin. So here we are testing it for a near distance. So the examiner here has kept a target right in front of the patient and asking him to tell whenever your is double. So the moment it is double, the patient will tell you that it is having a problem. So the double is basically at point of break. So you record it as a break point with values written at the side of your prism bar. Then you again reduce it to get the value for recovery. You repeat it at least 2 or 3 times so that to confirm your value. So this is how you do your negative fusional vergence. Coming on to positive fusional vergence, so it is done with your base out prisms. Assess the amplitude of your convergence. Expected findings are your, for distance you will get 11 plus or minus 7 and recovery at 7 plus or minus 2. For near, you generally get a value of 19 plus or minus 9 and a recovery of 14 plus or minus 7. So these are all the values which we generally expect. So here is one video which will tell you how we take it for near. So it is said that we generally move the prism bar at a speed of 4 prism per second because you have good amount of your convergence. So very quickly you can converge it. So you need to ask the patient the moment it becomes double. So the moment it is double, that is your break point, and then you will reduce the amount of prism to get again back onto the recovery. Many times you will find out that the patient are even exceeding the prism bar scale itself. They have good amount of convergence, so even the scale will end up and the patient will say that there is no blur. So generally we take the end value as the value for your PFV. So what is the point of assessing the negative fusional vergence and positive fusional vergence? So positive fusional vergence means that how much amount of your convergence I can do. So a patient with a problem with your convergence insufficiency will give you a lesser value for near, a PFV with a lesser value of near, whereas a patient with your what we say convergence excess will give you a higher value for PFV. Also, there is a what we say equilibrium between your positive and negative fusional vergence. Whenever your positive fusional vergence decreases, automatically the divergence muscle will start overacting, and because of that you will get a higher value of your NFV. So always take into account both the values and see if one is reducing, is the other also increasing, because many times what happens, your convergence and divergence both are affected, so the vergence facility is reduced. So in that scenario, what will happen, both your convergence and divergence, that is NFV and PFV, both will have a reduced value. Coming on to the Vergence facility, now this is the last test which we generally have into your orthoptic evaluation. So this is done basically with the help of your prism flipper. So Vergence flipper, which we say. So here we use a prism bar which are attached one over the other. So one is a 12 prism base out, which checks your convergence, and then there is a 3 prism base in, which is your for your divergence. So what you do is you keep a particular line target right in front of the patient at near, and then you keep your prism moving up and down. So the moment the patient says it is single, you will change it to your base in. The moment he says again it is single, you will change it to the base out. So generally this is how the prism looks. So you can keep it in hand as well as you can use a rod to attach it. What this particular test tells me about is, even if the amplitude of your vergence is good, the ability to change in between your convergence and divergence is important. As I said earlier in an example, if I'm looking at a laptop and then I'm looking at distance, so I need to converge while I'm looking at near. The moment I look at distance, I need to diverge my eyes. So if I'm unable to change the vergence facility, or rather I cannot change the vergence very quickly, that will again give me problems in my daily routine. Even if it is getting clear, but if it is double, that is again a problem for me. So this is how you generally assess your patient with an orthoptic evaluation facility. As I already said, we are using a prism of your 3 base in and 12 base out. So here's simple. What you do is, we already checked with NFV and PFV about what is the amplitude, or rather what is the quantity of your convergence and divergence you have. But before that, we need to understand the difference between your convergence and divergence. So you need to understand that not only the amplitude, but also the quick switch between the generation and relaxation is very important. So as I said earlier, like for example, you are looking at near, for example, a small child is looking at the book, he's writing something, he's converging. The moment he looks at a distance, is he able to quickly diverge his eye and see the board single? So if he is unable to have a good amount of vergence facility, so what will happen? That would lead to something called as your diplopia for distance. Or the moment he looks from distance to near again he will have diplopia, and it will take time for him to get single. So this is where commonly many patients complain. So you need to check not only about the quantity of your what we say the vergences you have, but also the quality, rather how quickly the patient can stimulate and relax the amount of your vergences. So it is again done with the help of this flipper. So now why 3 and 12 prism? Many studies have been done with using different combinations, but most of the studies said that the best value, or rather the best amount, or rather the best method to do it is with the help of your 3 base in and 12 base out. So generally you find the this kind of your Vergence facility prism with the help of your 3 prism base in and 12 base out. So just to make you things simple for you, let's say if you don't have this prism bar with you, like for example you are not having this prism bar, what you can do is you can use two loose prisms. Now the simplest way I do into the clinic is you put a trial frame right in front of the patient's eye and you put 3 base in. Okay, now, or either what you can do is you can use your 12 base out, any one of the lenses you put right in front of the patient's eye, and the opposite power which you require. Let us say that I kept around 3 base in right in front of the patient's eye. So now to create an effect of 12 base out, what I'll do is I'll keep 15 base out in front of it, in addition to the 3 base in. So the total effect which will come in front of the eye, the patient will have a 12 base out. So what I need to do is to flip the lens. Rather than flipping, I will keep the lens which is 15 base out, then take it away. So when I keep it into the trial frame, that will give me a 12 base out effect. The moment I remove it, it will again be a 3 base in effect. So that is very simple how you can do it. Or else if you are unable to do with that method, you can take two prism, loose prism into your hand, take it one over the other such that 3 base in is your inside, your 12 base out, and you can just keep it up and down. Very easy method and very easy to assess your patient's Vergence facility. Simple, you do it at near because you cannot ask your patient to look at distance directly. So generally this test is performed at near. So you give a line target to the patient and perform this, and you can get that what amount of Vergence facility the patient has. So the normal reading which ranges is somewhere between 4 to 6. Now again, there is a standard deviation in many books. So normally a patient should have a good amount that is between 5 or 6. That is quite acceptable. So in different literatures, different number of values are given, but 4 to 6 is quite acceptable. Lesser if it is, then you understand that the patient has Vergence infacility. So the patient has to be given exercise such that he can very quickly relax and generate the amount of convergence and divergence. So this was the last test which we have in your orthoptic evaluation. So I would thank everyone who are present right now and whoever will be seeing it in future with the video mode. So thank you for your patient listening and your attendance in such a short time, and also giving your important time in such a busy schedule. I hope every one of you understand the techniques of your orthoptic evaluation. So once you understand the way we evaluate it, we can apply the particular amount of knowledge to diagnose that what the patient is actually having. So once you get this results of this data, then you can group the data and actually diagnose the condition, because a correct diagnosis will lead to a correct treatment plan. So doing the evaluation is one of the most important pattern. So if you don't do the evaluation properly, then you will land up with a misdiagnosed factor, and that would lead to a wrong treatment, or rather an inappropriate treatment for the patient. So thank you everyone, and with this I would end my lecture. Manasvi, over to you.
Thank you so much, sir. That was a wonderful presentation, and I'm sure, like me, our audiences have also immensely enjoyed it, which is pretty much visible with the responses here. And so, with your permission, I'd just like to move on to the discussion.
Yeah, sure.
So, the first question we have is from Miss Anjali Shaha, who wants to know why it is necessary to evaluate the sensory fusion first.
Sensory fusion, when we say, now for example, as I earlier said, that motor fusion and sensory fusion are two different aspects and they work with each other. So if, for example, you have good amount of motor control, but you are unable to fuse it, like for sensory fusion, I need to keep the images single. So sensory fusion gives you an idea that if even the patient is having a Phoria, is he able to use his sensory fusion and make it single? And if that is present, then there is a good chance that the patient can be treated very well. So let's say if there is a patient who has a good amount of your Phoria and he is having a good sensory fusion at the same time, that means the patient has still the ability to control his whatever we say convergence or divergence. So the moment you start giving the therapy to this patient, the protocol would be different here. So whenever we plan a treatment, we need to understand what are the abilities the patient is having. Is he able to do it a sensory fusion properly? Is he able to fuse it? Because many times we see that the patient is aligning the eyes, but the sensory fusion is not present. The brain is unable to cope up. So then the line of treatment would be different. So that is why it is again important for sensory fusion to assess properly, because sensory will give you that what quality the vision is having, whereas quantitatively when I ask about the other ways, so that will only give you the quantity, that this much amount of singularity is present, that this much is the amount where the patient can see. But is the patient able to keep it single, or rather what we can say use both the eyes together? Because many times even after using your what we say your fusion, motor fusion, you start suppressing at one point. So sensory fusion is again a very important factor, because after sensory fusion, then only you can perceive what is called a stereopsis. I hope that would answer her question.
Thank you so much, sir. Moving on to the next question, Ms. Deepshika Busal wants to know why the patient with diplopia see five light, that is two red and three green inverse four dot. And while we're on it, could you also explain to our audience the phenomenon, the difference between crossed and uncrossed diplopia in the words four dot? Because a lot of our audiences are students.
Okay, so answering the first question first. So they said why five lights. So simply what happens, the right eye, if I say the right eye is having red and the left eye is having green, so in a normal condition, what would happen, that the right eye can see only one light. Okay, so the white light which is present is actually seen by both the eyes because of the presence of your filter. So the white light is colored with red as well as green. The red light which is present will be only seen by the right eye because of the presence of filter, as it would occlude all the other lights except white and red. The green, the one which is present into your left eye, the green will only see two green, and it will not allow you to see the red one. What happens in a patient with diplopia, that both the eyes are actually working separate, they are not in coordination. What happens, the right eye is looking at the white dot separately, whereas the left eye is looking at the white dot separately, and they are coloring that particular object with their own filter. So what happens, the right eye is looking at two red objects which are on one side, whereas the left eye is looking at the three green objects which are perceived by it. So now what is crossed and uncrossed diplopia? So cross diplopia means when the object which is to be seen by the right eye is seen onto the other side of the eye, that is it crosses the visual area. So let's say that the patient is seeing five lights. So right being red, the red should be in front of your right eye, that is uncrossed. That means it is right in front of my eye, it is not crossing, so that is uncrossed. But if the right eye image, which is your red images, it is crossing on towards the left side, that means it is crossing the visual area, that is called as your cross diplopia. Now, to explain this, it is actually a big phenomenon. The simplest understanding which I can tell you is between the retinal correspondence, that is nasal and temporal retina. So when you are having an exotropia, what happens? The eye, which the fixation point which is coming, that is not coming onto your fovea, rather hitting your temporal, or rather what we can say the temporal retina. And because whatever is perceived onto the temporal retina will be seen onto the nasal side, that means it crosses it over. So that is the reason why you see your cross diplopia onto your exotropia. Whereas patients with EZO, what happens? The eye is moving inward, leading to the image to form at your nasal retina. So because the image is forming onto your nasal retina, the image will be right in front of the eye and onto the same side. So the simplest understanding for students, so if the right is having red and left is having green, so if the same color is present on the same side, that is called as uncrossed diplopia. Okay, so if the right side is having red images and green side is having your left images, so that is what is called as your uncrossed diplopia. And if they are crossing each other, for example, on the right side you see three green and onto the left side you see two red, so that means the images have crossed each other, so that is what is called as your cross diplopia. I hope that would give the answer to the question.
Thank you so much for the answer, sir. While similarly moving on towards the next question, Mr. Janakiraman has a question. Miss, I think I don't know. Janakiraman has a question. In Flipper, which side is better to start with plus or with minus for both monocular and binocular procedure?
Okay, for all the tests, not only about flipper, it is about all the tests, whichever you do, it is always suggested to go for plus first, because we do not want your accommodation to get too much exerted or too much used so that it is difficult for you to relax. So even if you are doing NRA and PRA, that's why I said NRA first, because NRA uses plus lenses, whereas PRA are using minus lenses. So whenever you do any test, it is always the relaxation test first and then your stimulation. Like for example, when we do your even the Vergence test, so always use divergence first and then go for convergence. Never do that completely converge the patient, because what happens when you go up till the extreme limit and then come back, it is difficult for the patient to relax. So whenever you're doing your plus lenses or minus lenses, whenever you have two tests, always go for plus first. So what happens? Simply you ask the patient to look from first plus and then go for the minus side. I hope that would answer the question.
And would it not, interfere with the values of the minus?
It will not. See, it is a simplest understanding. If I have the good amount of relaxation, I can very because your accommodation stimulation doesn't have any role to play with your relaxation. Uh, Another example in a layman term I would give you. For example, you are resting and then I suddenly ask you to work. You can work with whatever limit you have. But at the same time, if you have already worked a lot and then I ask you to relax, the muscles will not very quickly, because they are already into a state of fatigueness. So what happens? The muscle have been already overused. They are into contraction, and from contraction to go into easily relaxing, that is quite a bit difficult at times. Because as I said earlier, if you are excessively using your muscles, they take time. Whereas if you are already relaxed, so even if it is at a normal point or even if it is after complete relaxation, the value of your stimulation would be same. That doesn't changes. But the value of relaxation will be very much dependent on how much exertion you have put. So that is the answer for the question.
Thank you, sir. Moving on to the next question, Miss Anjali Saha wants to know, how can we eliminate monocular cues while performing the stereopsis?
The simplest way is to using of Randot. Already, as I said, because there are the charts are made in such a way, because of the fact that Randot stereo test are, the name itself come because of the randomization. Whereas when you take Titmus fly test and all, the moment you will tilt your head a bit because of the polarizing filter, you can see two different images easily. So you are very, if the patient is a bit smart, or rather better, many times childs do this. So they try to guess. So the moment you say, no, this is not right, this is right, the moment they will start tilting and they will understand that the moment I tilt, I can see. So the first thing for this is you either keep the posture very straight, doesn't do not allow your patient to tilt, or rather what we say, to see from the corners. But it is always better to use a random dot stereo test to get a more accurate and a better value.
Thank you, sir. Thank you for the answer. Moving on to the next question, Mr. Ananta Paudil. He asks to differentiate between the vision therapy and orthoptics.
Okay, vision therapy and orthoptics. So when we say the term orthoptics, it was something derived very, very early. So orthoptics basically deals with the evaluation and the same techniques to treat you. So as I said, if you are having difficulty in your plus lenses, so I will give you more of your plus lens therapy. Now vision therapy is nothing but a higher concept of it. So in vision therapy, what we do is we have treatment for others as well, like amblyopia and everything. So vision therapy basically deals with the ability. So as a average, if I say, they're not very much different from each other, almost similar one on the other hand, but one of them have a lesser of your more of your, what we say, the evaluation factors. The other uses your rather concepts like neuroplasticity and everything. In orthoptics, generally what we see are accommodation and Vergences mostly, whereas vision therapy, when we say, you have further more better ways, like your learning disabilities, then your amblyopia, and many other such things to be very well treated. So orthoptics, what we can say, it is basically dealing with the assessment of your accommodation and Vergences and treating it with the same line of help. Like example, as I said, if I'm unable to converge, what would you do? You would rather give me convergence therapies. So that is my problem, you are giving me the particular therapy. Whereas orthoptics, the way of orthoptics, when it is used in conjunction with treatment of your amblyopia, that is your vision therapy. Or if I would say, more or less they are quite same, but vision therapy uses more advanced techniques. I hope that is the answer.
Thank you for the answer, sir. Similarly, the next question that we have received is from Miss Sakshi, who wants you to explain the direct and indirect tests of versions.
Okay, direct and indirect test. I guess I have already explained it in the video. So direct and indirect, when we say direct is that when I'm directly checking your vergence without any accommodative target, like your NFV and PFV. So when I'm checking with a line target, so what I'm doing is that I'm directly assessing that how much you can converge or diverge. And when I say the indirect method, so indirectly I can assess it with the help of your NRA and PRA, as already discussed, because the moment I put plus lenses in front of your eye, that will lead to reduce your accommodative convergence, and you need to use your fusional convergence to cope up with it, vice versa with your PRA. And indirectly with the help of your MEM also you can find it out. So what happens many time, if you see you get a patient with a normal amplitude, as we checked with minus lens method, that the patient was having a very good amount of amplitude, but when you check with MEM, he's having a lag of accommodation. Now that doesn't correlate very easily, because already when I saw that the patient has a good amount of amplitude, then why this lag of accommodation? So now this lag could be because of that the patient is converging excess. So to reduce the amount of convergence, what the eye will do is it will reduce the amount of accommodation which is exerting, vice versa with your convergence insufficiency. So if the patient has less amount of convergence, what will it do? It will start to accommodate more so as to attain more amount of accommodative convergence. So I hope that was the answer for direct and indirect test.
Thank you so much. Thank you so much. So we're almost at the end of our questions now. The last question that we've accepted is by Ms. Shubhi, who wants to know why accommodation and convergence occur simultaneously and how do they occur?
So to understand this, it is one of the most basic chapters of our optometry. So
The triad,
not,
sir?
yeah, the triad, but at the same time we need to understand what is vision. So we have not one eye, but we have two eyes. So two things which has to be very cleared. First of all, the clarity of the image. The image should be very much clear, as well as it has to be single. So to keep the image clear, what I use is called as accommodation, and to keep it single, what I use it vergence. So it has been developed within your human body that the moment you accommodate, so your brain knows that you are looking at something near. So the moment you are looking at something near, it gives you a particular signal from the brain centers to the Edinger-Westphal nucleus. There is a center called as the Edinger-Westphal nucleus. From there, there goes again a signal to your medial recti muscle that if I am accommodating for so and so diopter because of the senses which are coming from your ciliary muscle, so if I am accommodating for a particular amount, so that much amount of convergence is required to make it the image single. So how accommodation is triggered? It is because of the retinal blur. So the moment there is a retinal blur, or rather a blurred image, you will start accommodating. But the moment there is a diplopia or there is a double image at one certain point, the message is then received into your Edinger-Westphal nucleus to apply convergence or divergence to make it again single. So the triad itself says that simple, that whenever you will accommodate, the brain will send signals to two things, that is your pupil as well as your medial recti. The pupil will become smaller so as you can have a sharper image or a lesser pinhole effect, which will give you a clear image at near, whereas your medial recti will converge to make the image fall simultaneously onto your fovea and to keep it single. So that is how your triad works, or rather how accommodation and convergence works.
Thank you so much for your answer, sir. I believe we're wrapped up with our questions now. On behalf of IBIDS and our audience, I'd like to extend thank you to Mr. Tarik Mallick for giving us your valuable time and the lovely experience that you have imparted on us today. So I'd just like to request you to share your experience on today's session.
So I think it was a very good session. I loved the reply and every question and all the answers what I got onto the comment section. I was actually seeing it onto my phone itself. So I'm very happy that so many people interacted and so many people actually went through this. I just hope that it would be helpful for them to understand the objectives and principle of orthoptic evaluation, and maybe someday or rather into their practice they will imbibe some of the procedures. So as I said in the starting of my complete presentation, that some of the particular things can be actually taken into your routine practice. Like for example, it doesn't take much time to check your NPA and NPC, or neither it takes many big fancy instruments to assess the complete orthoptic evaluation. So next time whenever a patient comes up with a asthenopic symptom, please don't just do with the vision and say there is nothing problem. Rather, spend some time and do a complete orthoptic evaluation. That will give you a new aspect or a new concept, as well as increase your field of practice. Because many people think that practicing orthoptics or binocular vision is quite a tough job, but once you start doing it, it is quite easy. So I hope everyone would take this knowledge and apply it into their routine practice. And for those students who have attended it, they would have understood, or rather try to learn more about it with their respective faculties, and they have more questions and more understanding about it. So I would again like to thank ForOptom for me inviting me onto this platform and giving me the platform to share my knowledge onto orthoptic evaluation. I hope you continue with the same more on more topics. So would love to see you all again in some other lecture in future. So thank you, and it was nice time with everyone, and goodbye.
Thank you so much. Thank you so much for your kind words, sir. It was an absolute delight on our part to have you here today. And this brings us to the end of the program. I would also like to thank our audiences for being ever so supportive, kind, attentive, and as always, interactive. On that note, I'd like to end this session. This was a live session and it will stay on YouTube for our audience's future references. Stay tuned for more sessions and programs by IBIDS and ForOptom. You can also visit us at www.foroptom.com for more information on ForOptom and IBIDS. Also, join us on social media, WhatsApp, Facebook, and Instagram. Stay home, stay safe, and have a great day. Thank you.